Hi guys, I want to discuss acute hepatitis in the hospital setting based on recent guidelines. So, the diagnosis of acute hepatitis requires a comprehensive differential to identify the underlying etiology, as the cause directs management and prognosis. Acute hepatitis is characterized by a rapid onset of liver inflammation, typically presenting with elevated liver enzymes such as an AST or ALT, often exceeding 1,000, and hyperbilirubinemia, and symptoms including fatigue, jaundice, nausea, and abdominal discomfort. A thorough history including travel, medication use, alcohol consumption, sexual history, and occupational exposures is essential. First, let's talk about differentials. Viral etiologies are primary considerations. Hepatitis A virus, transmitted via the fecal-oral route through contaminated food or water, typically causes a self-limiting illness, but may lead to significant dehydration or, rarely, fulminant hepatic failure. Hepatitis E virus, similarly transmitted, is increasingly recognized in developed nations, particularly in immunocompromised patients or those with zoonotic exposures, such as consumption of undercooked pork. Hepatitis B virus, spread through blood, sexual contact, or perinatal transmission, may present acutely with arthralgia and rash, and while most cases resolve, progression to chronic infection may occur. Hepatitis C virus, primarily bloodborne, is less common as an acute hepatitis cause, but may be asymptomatic initially, complicating diagnosis. Hepatitis D virus, a defective virus requiring co-infection with hepatitis B virus, can exacerbate hepatic injury. Non-hepatotropic viruses such as Epstein-Barr virus associated with mononucleosis, cytomegalovirus, particularly an immunocompromised host, and herpes simplex virus may cause severe hepatitis in neonates or immunocompromised patients. Less common viral etiologies include varicella zoster, parvovirus B19, and adenoviruses, especially in pediatric or transplant populations. Toxic etiologies are critical to evaluate. Acetaminophen overdose remains the leading cause of acute liver failure in the United States, with hepatotoxicity driven by the accumulation of N-acetyl-P-benzoquinonamine, a toxic metabolite depleting hepatic glutathione stores. Doses exceeding 150 milligrams per kilogram, or 7.5 grams total in adults, can precipitate severe injury, often compounded by delayed presentation. Alcohol-induced acute hepatitis results from excessive ethanol metabolism, leading to steatosis, oxidative stress, and cytokine-mediated inflammation. Idiosyncratic drug reactions associated with medications such as isoniazid, rifampin, anticonvulsants like phenytoin, or herbal supplements like kava or green tea extract are unpredictable and may involve immune-mediated or metabolic mechanisms. Clinicians should be aware of emerging data on checkpoint inhibitors such as anti-PD-1 therapies causing immune-regulated hepatitis in oncology patients, often presenting with mixed hepatocellular and cholestatic patterns. Autoimmune hepatitis, a type 1 or type 2 immune-mediated condition, is characterized by autoantibodies like anti-nuclear antibodies, anti-smooth muscle antibodies, or anti-liver kidney microsomal antibodies, and elevated immunoglobulin G levels. It predominantly affects women and may present acutely with severe transaminitis, mimicking viral hepatitis. Genetic predispositions such as HLA-DR3 or HLA-DR4 increase susceptibility, and environmental triggers such as viral infection or drugs may precipitate onset. Ischemic hepatitis, often termed hypoxic hepatitis, results from inadequate hepatic perfusion, commonly seen in cardiogenic shock, septic shock, or hypovolemic states. It is marked by a rapid rise and fall in transaminases, often exceeding over 10,000 units per liter, reflecting central lobular necrosis. Veno-occlusive diseases like Budd-Chiari syndrome caused by hepatic vein thrombosis present with hepatomegaly, ascites, and elevated transaminases. Risk factors for this include hypercoagulable states like myeloproliferative disorders or factor V Leiden mutation. And diagnosis is confirmed by Doppler ultrasound or MR venography. Metabolic disorders, though rare, are significant. Wilson's disease, an autosomal recessive disorder of copper metabolism due to ATP7 gene mutations, may present acutely in young patients with hemolytic anemia, Kaiser-Fleischer rings, and low ceruloplasmin levels. Acute fatty liver of pregnancy linked to long-chain 3-hydroxyacetyl-CoA dehydrogenase deficiency typically occurs in the third trimester, presenting with microvascular steatosis and potential multi-organ failure. Alpha-1 antitrypsin deficiency can cause acute hepatitis in infants or in adults with periodic acid shift positive globules on biopsy. Vascular and environmental causes include portal vein thrombosis, often associated with cirrhosis or malignancy, and heat stroke, which induces direct thermal injury and cytokine release. Amatoxin poisoning from the ingestion of mushrooms causes severe hepatotoxicity via RNA polymerase II inhibition, with a biphasic course of gastrointestinal symptoms followed by liver failure. Clinicians should also consider rare parasitic infections such as acute schistosomiasis or toxoplasmosis in endemic areas or travelers, which may mimic viral hepatitis. Hospital management of acute hepatitis focuses on stabilization and etiology-specific treatment and complication prevention. Patients with coagulopathy, defined by an INR greater than 1.5, or hepatic encephalopathy, indicating acute liver failure, require immediate admission to ICU. IV fluids can be administered to maintain hemodynamic stability, with close monitoring for hypoglycemia, which is a common complication due to impaired hepatic gluconeogenesis. Comprehensive lab eval includes viral serologies, toxicology screens, autoimmune markers, ceruloplasmin for Wilson disease, and imaging such as ultrasound with Doppler or CT to exclude biliary obstruction or vascular thrombosis. Etiology-specific therapies are initiated promptly. For acute hepatitis B virus with severe presentation, nucleoside analogs such as entecavir or tenofovir are recommended to reduce viral replication. Acute hepatitis C warrants direct-acting antivirals tailored to genotype and renal function. Hepatitis A and E viruses typically require supportive care, including hydration and electrolyte correction. Acetaminophen toxicity is treated with N-acetylcysteine administered IV to replenish glutathione and detoxify metabolites, even effective in delayed presentation. Autoimmune hepatitis responds to steroids such as prednisone 40 to 60 milligrams daily, often with azathioprine for maintenance. Alcoholic hepatitis management obviously includes alcohol cessation, thiamine, folate, and magnesium, and you can consider steroids if their Madry's discriminant function is greater than 32, as long as you have ruled out infection or GI bleeding. Complications of acute hepatitis demand vigilant monitoring. Hepatic encephalopathy from ammonia accumulation can be managed with lactulose or rifaximin, but this can also cause cerebral edema, which can require mannitol or hypertonic saline. And you might need to monitor ICP with devices. Worst case scenario, you can do dialysis to remove ammonia if you're worried about herniation from cerebral edema. Coagulopathy can be corrected with vitamin K or FFP if there's active bleeding. Prophylactic antibiotics can be used, especially if there's ascites like ceftriaxone. It's very critical to do nutritional support with high protein dietary supplements. Referral for liver transplant is indicated when acute liver failure, defined as hepatic encephalopathy within 8 weeks of jaundice onset. This includes a poor prognosis. The 2025 American Association for the Study of Liver Disease guidelines recommend early consultation with a transplant center. The King's College criteria remain the standard for identifying transplant candidates. For acetaminophen-induced acute liver failure, referral is warranted if arterial pH is less than 7.3 after resuscitation, or if all three criteria are met. An INR greater than 6.5, a creatinine greater than 3.4, and grade 3 or 4 encephalopathy. For non-acetaminophen etiologies, referral is indicated if the INR exceeds 6.5 alone, or if any of the three following are present: age less than 10 or greater than 40, etiology other than hepatitis A or E, or due to an idiosyncratic drug reactions. In conclusion, acute hepatitis management requires a systematic approach to identify the etiology, initiate targeted therapy, and manage complications with prompt recognition of causes requiring transplant evaluation. Clinicians should consult the 2025 American Association for the Study of Liver Disease and the European Association for the Study of Liver guidelines for ongoing updates. Let me know if you have questions. Let me know if you have any cases pertinent to this, and drop your comments below. Thanks for listening.